Good evening, everyone. So this is the APSC President Session 2024. And thank you for joining this session. And I'm very happy to invite many presidents and young doctors from all APSC countries. And this session, so we like to share the situation of APSC countries regarding heart failure and intervention. And we would like to discuss about future collaboration between APSC and JCS. And firstly, so we will invite the representative of this conference and Professor Kenichi Hirata from Japan. So.
Okay, hello everyone. So thank you very much for joining us. This APSC President session at JCS 2024. Today it's a little bit cold, but I hope the discussion is very hot. So, thank you very much. So now, there are many audience in this conference, and there are a lot of sessions. So I hope participants from the APSC countries enjoying this JCS conference and looking around everywhere. And then please keep collaboration with APSC and JCS in future. And young cardiologists, JIYC is young doctors in JCS. So they are organizing this conference. And please enjoy this science. Thank you very much.
Thank you, Professor Dr. Hirata. So let's move on to the first theme. So the first one is the heart failure in APSC. So we invite two chairpersons, Professor Issei Komuro from Japan and Professor Abdullah Al-Shafi Majenda from Bangladesh. So please start the session.
Okay, let's get started. Heart failure in APSC. So first, I would like to invite Professor Wen-Jong Chen from Taiwan. He will give us a keynote lecture titled Peculiarities and Issues to be Solved of Heart Failure in APSC. Professor Chen, please.
Thank you, Mr. Chairman, ladies and gentlemen. It's my great pleasure to share with you about the epidemiology of heart failure in Asia. Today, I will make a brief introduction of epidemiology of the heart failure and will introduce recently published guidelines related to heart failure from Taiwan Society of Cardiology. I have no CFI. Globally, the prevalence of heart failure is around 1 to 3%. And although the incidence of heart failure is slightly decreasing, but the prevalence of heart failure still keep on increasing because of the aging of the population and the management of the improved management of the patient extend the life expectancy of these people. The heart failure across Asia, we share the same healthcare burden, but difference in organization of care because Asia is a huge area, includes multiple ethnicities, and we have different population, life expectancy, mean age, and GDP per capita, as well as we have different healthcare organization or healthcare expenditures. Even within Asia, there is highly heterogeneous demographic character were noted. For example, the data from Asian Heart Failure Registry for half left. The Filipino had highest prevalence for hypertension, but the Malay had highest prevalence of diabetes and CAD. For the heart path, again, the highest prevalence of hypertension is Chinese. For the highest prevalence of diabetes, CAD, obesity, chronic kidney disease were Malay. The Japanese and the Korean had higher prevalence of atrial fibrillation. If we compare the Western versus Asia, we noted half-life in Asia is characterized by a young age, lower BMI, higher prevalence of diabetes, but low prevalence of COPD compared to Western patients. For HeartPath, again, HeartPath in Asia is characterized also by a low BMI, higher prevalence of diabetes and atrial fibrillation, but low presence COPD. Another study also supports the higher prevalence of diabetes in the Asia-Pacific area as compared to the Western country. The 1-year mortality rate in Asia-Pacific area would be 12%, and then the heart failure with hospitalization within 1 year would be 15%. Another report said the 5-year mortality of heart failure in Asia-Pacific area would be around 50%. Some reported up to 70% for 5-year mortality. We have done the TSOC registration since 2020-2022. We collect 2,800 patients. Most of them are half-life patients. And as shown here, the half-life patients seems older and predominantly females. Concerning about the etiology in Taiwan for the half-life, both two studies suggest the number one etiology would be ischemic heart disease. The second would be dilated cardiomyopathy. For heart failure with mild reduced ejection fraction, also again is ischemic heart disease responsible for the most etiology. But for the HeartPath patient, number one etiology would be hypertension. The second one would be tachycardia-related heart failure. The third one is ischemic heart disease. If we compare the HeartPath with HeartLife, heart patients are generally older with female predominance, exhibit higher BMI, elevated blood pressure level, and great prevalence of comorbidity compared to HeartLife patients. In recent 3 years, we published 3 consensus or guidelines from Taiwan Society of Cardiology. The 2021, we published novel therapy for type 2 DM. We first suggest a stepwise pathway according to LV ejection fraction and renal function. In 2023, we published pharmacological treatment of chronic heart failure. We integrated new effective therapy and prioritized them in the management of Asian patients. In this year, we published diagnosis and treatment of HeartPath, suggest a new modality for diagnosis and management for HeartPath. For example, as shown in figure, the patient with cardiovascular or renal disease or multiple risk factor would like to do the LV ejection fraction with echocardiography. If LV ejection fraction less than 40, the first line recommended therapy would be SGLT2 inhibitor. Second line would be GLP-1 agonist. As shown in the table for the half-life patient, we recommend ACI, ARB, or ARNI, and the beta blocker, MRA, and the SGLT2 inhibitor. For the heart failure with mild reduced ejection fraction, we treated most of them as the half-life. But for HeartPath, the most evident data from the SGLT2 inhibitor and ARNI, and some mild data from ARB and MRA. Instead of suggest the conventional sequencing strategy, we would like to recommend rapid sequencing strategy. It means first we use the SGLT2 inhibitor with MRA for 2 weeks, then observe the blood pressure. If blood pressure more than 100 mmHg, we will first use the ARNI, which is okay, followed by the beta blocker. But if the systolic blood pressure less than 100, we would recommend beta blocker first, and BP tolerable, then followed by the ARNI. The repeat sequencing strategy would decrease the cumulative time. For 6 weeks, we can let the 4 Peter on the patients. For the heart failure preserved ejection fraction, the supervised exercise training is recommended for patients with HeartPath to improve heart failure symptoms, exercise capacity, and quality of life. Weight loss either by the lifestyle modification or GLP-1 agonist is recommended for obese patients with heart path to improve heart failure symptoms, exercise capacities, and quality of life. Diuretics are recommended for congested patients with heart path to relieve symptoms. SGLT2, including dapagliflozin and empagliflozin, are recommended for patients with heart path to reduce the risk of worsening heart failure events and cardiovascular death. Thank you for your attention.
Yeah, thank you very much, Professor Chen. Are there any questions for Dr. Chen? Okay.
Thank you, Professor Chen, for your nice presentation. The one peculiarity may be due to the increased prevalence of the peripartum cardiomyopathy leading to the heart failure with reduced ejection fraction in this region. What is your opinion?
So-called peripartum cardiomyopathy in Taiwan is not so common because we have good system to care the children and the mother in their pregnant stage.
But
So
if we
much.
consider the South Asian population, the peripartum cardiomyopathy is still a good, important etiological diagnosis of the heart failure with reduced ejection fraction in the female patients.
Most of them is diabetic cardiomyopathy. I think after myocarditis or so-called idiopathic, peripartum cardiomyopathy still just a minor portion.
And another peculiarity may be due to the management of the heart failure with reduced ejection fraction or any heart failure patient in this region, particularly in the South Asian region, where we cannot use the recommended drugs always in the full doses. For example, in Bangladesh, we use the half dose of the sacubitril valsartan in the heart failure with reduced ejection fraction. Half dose means 12.5 milligram twice a day, and it is effective. And we have undertaken already a study whether this half dose is good enough for the long-term effect of the management of the heart failure. There's a good example, but this is not recommended. We don't get the tablet of the 12.5 milligram, and government does not approve the production of this dose. But we have to break down the 25 milligram tablet and then use it.
Fortunately, in Taiwan, we have so-called national health insurance. The all reimbursement was covered by the government mostly.
Regarding he is already on the mic. Yeah.
Thank you, Chairperson. Professor Chen, I mean, the APSC accounts for many members, millions of members. With the mortality, 1 year mortality of heart failure, still very poor, 10 to 12%. Would you recommend a population screening, like how you would for colon cancer, for example? If we did for a population, at what age and what tests would you recommend?
In Taiwan, we do not recommend routine screening. But if the patient has symptoms, we measure the proBNP or BNP. If it is high, then followed by the echocardiography. Then we can have early diagnosis. Then we promote the so-called adhere to the guidelines treatment. For example, the 4 pillars for the heart valve. And for heart path, we start SGLT2 and also the ARNI or MI and ARB.
For countries without the National Health Insurance Scheme or reimbursement, like many parts of the APSC, would you change the strategy or would you recommend us to follow the guidelines?
I would like to recommend if the so-called budget limitation, if patient have symptoms, I think the proBNP or BNP should be due first. If they are elevated, echo would be okay because echo is more labor intensive and I think more expensive than the proBNP. At least in Taiwan, it's a situation.
Thank you.
I think you.
Okay, thank you. So I'm sorry, I have one request. The schedule is quite tight, so I'll move to could you come to the doctors and president from to here? Could you come to the president in charge of heart failure. Yes, and the young doctors are behind. Okay.
So first, when I ask young doctors to present for only 1 or 2 slides, around 2 minutes. So first speaker is Dr. Misato Chimura.
Thank you, Chairperson. I would like to talk about the current status and the challenges of heart failure in Japan. My name is Misato Chimura from Osaka University. See, I provide the basic information on heart failure in Japan. The number of heart failure patients is increasing due to aging population, signaling the onset of heart failure pandemic. The right chart indicates the data of Japanese Registry of Acute Decompensated Heart Failure Registry, the Road Heart Failure Registry. It is a retrospective multi-center and nationwide registry in 2013. It is evidence that the prevalence of HFpEF is highest, reflecting the increasing number of heart failure patients among elderly. Following this, HFrEF and MREF are observed in subsequent order. Moving on to the etiology of HFrEF and HFpEF. It is noteworthy that the HFrEF patient had the highest prevalence proportion of CAD, coronary artery disease, across the Japanese multiple registries. However, HFpEF demonstrated that the highest prevalence of HHD, hypertensive heart disease, across the many Japanese registries. In Japan, when the number of heart failure patients increased, several challenges exist. Firstly, there is an inefficient awareness regarding heart failure. First, this is attributed to insufficient awareness among the Japanese population regarding heart failure. Additionally, the number of heart failure patients increases. Doctors outside the field of cardiology are becoming more involved in the treatment of heart failure. Insufficient knowledge regarding acute and chronic treatment strategy result in adequate care for heart failure patients. Another challenge is difficulty of diagnosing heart failure. With the increasing aging population, the number of patients with multiple comorbidities is rising. For example, it has become difficult to determine whether the exhaustion dyspnea is due to respiratory disease originating from the heart or a combination of both and others. Thank you for your attention.
Okay, thank you, Dr. Chimura. So next, Dr. Zhenwei Chen from Taiwan. Please start.
Hello, everyone. So I just sit here, or should I come? Okay. And hello, everyone. And I'm Dr. Chen Zhenwei from National Taiwan University Hospital. And today I have nothing to disclose. Next, I want to share about some basic information of heart failure in Taiwan. First, he asked us to show the epidemiology and definition of heart failure in Taiwan. First, we could see from the left picture, as we could see the blue line, that the incidence of heart failure in Taiwan until 2016 is around 2.19. And the prevalence gradually increased to 2016 is around 1.4. But its projection simulation analysis until 2024 is around 2%. And as to the definition of heart failure in Taiwan, we could see from the 2023, Dr. Chen has just presented our heart failure consensus. We propose a new classification of heart failure guideline according some treatment effects. As we could see, generally, if we have the ejection fraction more than 15, it's called the HFpEF. However, we just divide it into if the ejection fraction more than 16, we have the heart failure with normal ejection fraction. And also, we have if ejection fraction less than 15, we all call them heart failure with reduced ejection fraction, and further divided into two parts. One is if the ejection fraction less than 40, is we will call it heart failure with severely reduced. If the ejection fraction more than 14, we call mildly reduced heart failure. Okay, so the next question is which heart failure is the greater problem? I think because the heart failure with preserved ejection fraction is more prevalent, so maybe it's a big problem. And what is the common etiology of HFpEF and HFrEF in Taiwan? I searched some data, but it's very difficult to attribute some etiology. I think the comorbidity is a more appropriate term. So I just searched data in our National Taiwan University Taiwan registry. We could see that in the HFpEF patient, around 80% have hypertension and 44% have CAD. Diabetes is around 26.5%. And in the heart failure reduced ejection fraction from the TSO heart failure reduced HFrEF registry, we could see the DM, the patient have DM accounts for 43.6, and the ischemia is around 41.8. Okay, so is the heart failure a major problem in Taiwan? It just assess to discuss the problem, just like Dr. Chen, our president in Taiwan, said. I think the biggest problem is our national health insurance problem. So as you could see, the left side is our guideline. 2023 heart failure guideline, we suggest use the rapid sequencing algorithm for the heart failure treatment. However, we could see our national health regulation in Taiwan. For example, for SGLT2, he is limited to the LV ejection fraction less than 40. And if we want to use SGLT2, we should use ACI or ARB first. And either he should tolerate the beta blocker at least 4 weeks. If patient still have symptoms, the SGLT2 is indicated. Another example is Entresto. Entresto is limited to the heart failure with ejection fraction less than 35. And also, we should have patient have use the ACI ARB first and use beta blocker for 4 weeks, and another combination with SGLT2 for 12 weeks. Then, if patient have persistent symptoms, we can use Entresto. So this is some discrepancy between the real world and our guideline. Yes, I think it's the biggest problem in Taiwan now. Thank you.
Thank you very much, Dr. Chen. So next speaker is Dr. Izian Mohammed from Brunei.
Hi, Dr. Izian from Brunei here. Next. So nothing to disclose. Next. Okay, so basic information. Next. Okay, so we just released our heart failure guidelines last year. So based on this, we define HFrEF to be EF of less than or equals to 40%, HFpEF to be more than or equals to 50% EF, and anything in between will be mid-range. And then we also introduced concept of improved ejection fraction as per what's shown there. Next. Okay, so we don't have registry data per se, but we're sort of collecting data about our inpatients from last year. So we're male predominant, Malay, 92% as well, with a median age of 61 years. They stay for a median length of about 6 days with a 1-year mortality of 12%, which is similar to what our keynote speaker mentioned for the Asia Pacific region. Next. Okay, so in terms of the breakdown, we predominantly have HFrEF with 65%. Next. In terms of etiology, predominantly this is caused by coronary artery disease, followed by hypertension, 12% there. Next. HFpEF only consists about 20% of our heart failure inpatients, with about 20% due to valve, and then cardiomyopathy consisting about 18%, and then about 26% we haven't figured out why they have HFpEF. Next. Okay, so is heart failure a major problem in Brunei? I think we're looking at a different perspective. Our median age is only 61 years, with retirement age above 60 years. It means that at least half of our heart failure patients are still in the working population. So this does affect productivity in the nationally. Readmission rate within 1 year is about 36%. I think, yeah. So with our high prevalence of non-communicable disease in Brunei, I think this is something that does contribute to our heart failure, and we're not going to be seeing the end of it anytime soon. Next. That's it. Thank you very much.
Thank you very much, Dr. Mohammed. Next speaker is Dr. Luigi Piero Segundo from Philippines.
Good afternoon. I have nothing to disclose. The most recent data on heart failure in the Philippines is based on an epidemiologic study based on hospitalization claims in our national health insurance system all over the Philippines. That's PhilHealth. So what I'll be presenting are inpatient numbers and also some numbers from a previous study done 10 years ago, only based on 6 hospitals. The current prevalence of hospitalization among heart failure patients is 1.6%, or that's 1,648 cases out of every 100,000 inpatient claims. And there's just little patients with this data, so I didn't write the numbers, but when they're available, majority currently have heart failure with reduced ejection fraction, and I've listed hypertension and coronary artery disease as the top 2 etiologies for heart failure. Our mean age, this is probably one of the youngest in Asia, is 52.6 years old. Note that majority of these patients belong to 40 to 59-year-old group, very well into the working population. So this is economically important. The hospitalization length of stay, though it has decreased from 10 days in 2007, has gone down, but it's still important, 5.9 days. And the in-hospital mortality rate, although it decreased from 10% in 2007, is still high at 8.2%. This is important economically because the computed burden is 1.84 billion pesos. That's just about $32.7 million. Mind you, that does not include reimbursement for implantable devices, ICD and CRTD. Next slide. So not all is failure in heart failure. We would like to share some little success stories. We're far from successful in changing the landscape, but in 2020, Philippine Heart Association, led by the Heart Failure Council, with the National Heart Failure Society of the Philippines, formed the National Heart Failure Network, which is meant to form a collaboration between hospitals, big and small, those with heart failure clinics, equipped, not fully equipped, to some sort of bridge the gap, and also collaboration among heart institutions and the government, in particular our Department of Health. One other success story is finally, for the first time, we now have our local clinical practice guidelines meant for the patients with heart failure with reduced ejection fraction, primarily for outpatient care, for primary care physicians, covering diagnostic tests, therapeutic tests, also cardiac rehabilitation, palliation, and also when to refer to heart failure centers. And hopefully in a couple of years, we can share better numbers soon. Domo arigatou gozaimasu.
Thank you very much, Dr. Secondo. Next speaker is Dr. Akara Ariyachai Panich
Thank you.
from Thailand.
It's my honor to be here. JCS give an opportunity to give a talk in front of the many president country. Thailand is kind of in the middle of the pack, middle income country, not up there, not developing country either. So all the number is kind of in the middle. Next slide, please. So we in Thailand, right? When I want to give the perspective about heart failure in Thailand, I like to put the word heart failure in Thai language, and that is a first problem. I do not know what heart failure is called in your country, but that word just means the same thing as kidney failure. Just change the word kidney and the heart out. People don't even know what is heart failure, right? They think MI, heart attack. They think fluid in the lungs. They think enlarging heart. They think not squeezing well. They think cardiomyopathy. So just the name is the problem. And the prevalence wise, we don't know the prevalence. The same as our colleagues from Philippines, we have the inpatient number, but we never have a national survey to know the prevalence of heart failure. So I cannot give you. But the inpatient wise, interesting, it is 40%, 10%, and 50% as a mildly reduced or mid-range, and a preserved EF, just the same as the percent cut off. We have everything for the diagnostic too, MRI, biopsy, genetic testing, NT-proBNP. We have all the treatment, we have transplant, we have LVAD, but none of these are close to enough, and many of these are not covered by the national insurance package. Like the LVAD, is out of the pocket cost for the patients, and the cost is probably like one good, really, really nice car, which not many people in Thailand can afford. We have the national guidelines since 10 years ago, and we recently updated in 22nd and 23rd. I have an honor to be the first author on the first one. And you can see that in the end, the guideline look the same as the international guideline. So I wouldn't call this a good guideline either, even though I'm the first author, right? Because we just copy everything. We don't have our own data. Next, please. I make only 2 slides because the author, the admin said, give me 2 slides. I think, what am I asking for APSC? I think APSC can be the first society to make a comprehensive guideline or statement for the people that having heart failure across multiple cultural and society difference. None other region in the world, Europe or the US, have this kind of guideline. What do you want us to do in the limited resource setting? Should we do echo or NT-proBNP? Bridging of the ARNI to ACE inhibitor, SGLT2. What do you want us to do with the SGLT2 that does not have cardiovascular outcome trial? Other people cannot say anything, but if we do the guideline the same as the Western country, we will say no other SGLT2, right? But it's cheaper, and why the patient have to pay because of we are so into evidence-based medicine. But we cannot do it because no one recommended that. So APSC, please. Okay. Heart failure for primary care. I think being in Thailand has a unique opportunity to think this way. Like the first chapter of our guideline would be like the best scientific review, right? And then the last chapter would be the primary care physicians. They should be advanced, they should be expert in up-titrating ACE inhibitor, beta blocker, MRA. If we look at the combination of these 3, the hazard ratio is close to 0.46 instead of 0.42 for the best Fantastic Four. With the disease being really expensive now, the heart failure, I think it would be more cost effective to start thinking about prevention. And in our region, it has to be rheumatic heart disease. It has to be gone. And then later on, hypertension, low salt day, low salt policy, salt tax has to be implemented. And then the last thing, I think this is the easy, the low hanging fruit. We should translate APSC heart failure guideline into many languages in our region, so we know that we have a central guideline for everyone. Thank you.
Thank you very much, Dr. Arya Chai Panich. So next speaker is Dr. Duan Pham Phung Long from Vietnam.
Okay, so I'm here. I'm here to represent about the Vietnam issues in heart failure and management, and I have no conflicts of interest. Next slide, please. So about the heart failure definition, in 2 minutes, I just say that the Vietnam National Heart Association have the recommendation for the management of heart failure in 2022, and our definition is quite the same to the ESC recommendation. That is the heart ref. Where is that? Okay, that is the heart ref, heart path, and heart failure with mildly reduced EF, which is the same. But we are focusing on, because our resources is limited, so we are focusing on mostly suspected with the sign symptom, and NT-proBNP is still an upgrade. A high level of lab test is not really available everywhere in Vietnam. About the epidemiology of the heart failure, we still lacking of the national registry. Okay, so we just based on the global incidence is about 300,000 to more than 1.5 million people in heart failure. But recent study in a single study, a single center study, we have in the University of Medicine and Pharmacy Hospital, we have a Bronze Plus HHACC heart failure management, and among more than 300 patients, we have mostly more than 64% is heart path, and the heart ref and heart failure with mid-range mildly reduced EF is quite the same level. So our issue is focusing on heart failure with preserved ejection fraction. So problem is Vietnam is that the multidisciplinary approach in heart failure is, and patients management in Vietnam is still not enough, because we are not. The the doctor from other society or maybe specialties is not connect each other. The second is lack of counseling and health education. It means that the doctors in primary care levels, they don't know about what should they do for that patient. The disruption of outpatient and heart failure management. So that's why I see some poster over there in JCS. We see the primary care and the change from inpatient to outpatient, and that is the problem that we still have. And the treatment availability of end-stage and device-based heart failure treatment, quite the same to Thailand's problems. The patient in our country have quite enough pharmacology department, pharmacology treatment, but for the end stage, we have very little choice for the patient. We have LVAD cases, but we don't really have. It's not really a problem. It's not really available everywhere in Vietnam. The second thing is that the challenge in heart failure management in Vietnam is that the challenge from the healthcare system, resources, and the challenge from the patient also, the public awareness, the high costs, and the comorbidities. Okay, next slide. So in conclude, the failure is and will be a major health problem in Vietnam. And Vietnam Heart Association released the guidelines, and we try to challenge the problems. And we have still lots of gaps in evidence and management of heart failure. And this is the map of that. These hospitals have established the heart failure care system in Vietnam, and we are trying to challenge all of the problems. Thank you.
Thank you, Dr. Doan. So next speaker is Dr. Sanda Chidambaram from India.
Good evening, and I'm privileged to be here before the august audience. And so I wanted to present the basic information of heart failure in India. India is a big country and a huge population. The prevalence of heart failure in India is due to coronary heart disease, hypertension, obesity, diabetes. Although the rheumatic heart disease are waning, still the prevalence is more in some of the rural side. It ranges from the annual incidence of 0.4 to 1.8 million. The prevalence is 1.3 to 4.6 million. The patients with heart failure in India, the groups are little younger than the higher income countries, with the average age of around 60 years at presentation. Although the India has reached, I can say in the intervention side, there are lots and huge development in the interventional side, but the heart failure still, the registries are not much properly done in heart failure in India. So recently, after the COVID pandemic, the government of India has taken a lot of measures to incorporate the heart failure registry in all the states in India. And regarding the definition, heart failure with preserved ejection fraction of LVEF or more than 50% with increased LVEDP and characterized by increased biomarkers, and mid-range ejection fraction of 41 to 49% with again the increased LVEDP with increased biomarkers, and reduced ejection fraction of less than EF of less than 40%. Yeah, in our heart failure registry, the heart failure with reduced ejection fraction occupies 72%. Although the heart failure with preserved ejection fraction, we are seeing more in these days. The common etiology with us, the president of Taiwan was told that the same etiology is prevalent in India too. Preserved ejection fraction, we have increasing age and hypertension, and reducing ejection fraction, we have coronary artery disease, hypertension, diabetes, etc. Next slide. So yeah, is heart failure a major problem in India? Yeah, it is a major problem in India because there is a huge rural-urban divide. In urban India, we have a huge infrastructure which can match high-income countries, but in the rural it is not so. The health infrastructure has not penetrated to the rural in India. The prevalence of rheumatic heart disease in rural India is still there, 1 per 1,000 school children. The estimated prevalence of heart failure due to coronary artery disease, hypertension, is ranging from 1.3 million to 4.6 million. And since the rural population has limited health access to health care, and also the limited health infrastructure, the public health system is overloaded, which makes access to basic services very difficult. And India has less than 2% penetration of health insurance. Now the government has come with Ayushman Bharat and CM Health Insurance Scheme, which has the aim of covering 100% of population, and which has now achieved 40% of the population so far. The emergency service in the rural area has now picked up with the introduction of 108 service, which is a very, very successful program in India, and it has now reduced the door-to-balloon time in India. The third thing I wanted to present is the transplant program in India is a huge success in the transplant side, because some of the data we have which can match the higher income countries regarding the transplantation. The Transplant is doing wonderful job there. The combination of inaccessibility, unaffordable treatment, and treatment delay possibly increases the incidence of heart failure in India, though we are in a developing stage and we can conquer this heart failure in India. Thank you.
Thank you, Dr. Sanda. So last speaker is Dr. Reju Mananda from Nepal.
Good evening. Thank you, APSC and Japanese Circulation Society for this opportunity. I'm going to give a short briefing about the current scenario of heart failure in Nepal. Those who are looking here for the official data, the prevalence of heart failure of Nepal, then I'm sorry to disappoint you, because there has not been any kind of official heart failure registry in Nepal, but there is one currently undergoing. Soon we'll hopefully publish it and we'll be able to present it in the next session. So we all know it's the heart failure, the burden is very high, especially in the low and middle income countries like Nepal, because of limited infrastructures, the technology and resources we all have. Heart failure is one of the most common cause of hospital admission, only behind ischemic heart disease in our country. And it's the very high morbidity and mortality as well. So among the two types of heart failure, the heart failure with reduced ejection fraction is slightly more common in Nepal. As 5 to 10 years before, the heart failure with reduced ejection fraction was more common in Nepal, but nowadays it's more or less coming to equal terms, and that's because mainly the heart failure with preserved ejection fraction is being more diagnosed as compared to 5 to 10 years back. So the most common cause of heart failure with reduced ejection fraction is the coronary artery disease, followed by dilated cardiomyopathy, the idiopathic cardiomyopathy. And among the heart failure with preserved ejection fraction, the most common the most common cause is the rheumatic heart disease, followed by valvular heart disease and the congenital heart disease. So is heart failure a major problem in my country? It's a major problem in every country as well. So the main issue in Nepal is the socio-economic status of the patients. The patients we are talking about here, the guideline-directed medical therapy, what kind of treatment should the patient have with the heart failure, what kind of follow-up we need to have, what are the markers we need to look up for in the follow-ups. In Nepal, around 50% of the patients, even if they have the symptoms of heart failure, they don't end up in hospital. They don't have those access to reach the hospital. And the next problem is the diagnosis. 50% of the, as I said, 50% of the patients who attend hospital are wrongly diagnosed at COPDs and being treated as a COPDs lifelong. And the other thing is the medications. Yeah, there are many medications which are being available for heart failure for reduced ejection fraction, as well as for heart failure with preserved or mildly reduced ejection fractions. But most of the medicines are available in Nepal, but some such as ARNI and SGLT2 inhibitors are still, they have recently been available for the last, I think, 2-3 months back. But still, the most of the patients of heart failure, those kind of medicines are still out of their reach. reach and way expensive. And recently, one of our professor have said that the insurance policy, health insurance policy, needs to look at these medications and to include them in their policy plan, so that the poor people, each and every patient who was diagnosed with heart failure should be able to get those medicines. And the next problem in my country is the patient compliance and the follow-up. Again, the same thing. The expenses of the heart failure diagnosis, the treatment leads up to patient incompliant. They tend to come for diagnosis, they take medications, 1-2 weeks follow-up, and then they suddenly disappear. Whether they are alive or they're expired, we don't know. So, but everything, as one of my fellows said, everything is not a failure. We are currently working on a heart failure registry, which will be published soon. According to that registry, the main problem is the in-hospital mortality was 4.7. It's 4.7. Among them, 3 months mortality among those who were discharged is 8%, and the total mortality among the heart failure patients is 9.9%. And among these patients, those who were included in the registry, the use of ARB, ACI was more than 70%. Beta blockers were used in 70% of people, and the novel drugs of heart failure, SGLT2 inhibitors, were just started using the patients. Were used in 15% of patients. So hopefully in next year, I'll be able to present a better data with better results. So I'd like to thank everyone involved here. Thank you so much.
Thank you very much, Dr. Mananda. Thank you very much for excellent presentation. All young doctors, we can understand the situation of the heart failure in each country very much. So let's move on the discussion time. So please.
Okay. It is a very novel idea to have the representations from the different countries and spoken by the younger group. It's very important. So I congratulate the organizers to have thought in their mind that it should be done. So 2 points is actually this area is a heterogeneous group. As the Indian speaker was telling that the India is a heterogeneous. Actually, this area is very much heterogeneous. Some countries are income is very high, GDP is very high, and in some areas the GDP is very low. The one thing I say in my lectures always on the heart failure, that the incidence or prevalence of the heart failure is the reflection of the good cardiovascular health services of that country, because you make the patient survived for a longer time to have the heart failure at the end. So in the past days, what happens? The acute MI patient died suddenly within days. But nowadays, the mortality of the acute MI decreases. So the heart failure due to the ischemic heart disease increases. So actually, this is a paradox. When there is a prevalence of the heart failure and the mortality, regarding the mortality, that is not the important. Important is at what age or at what stage the heart failure becomes overt heart failure. That's very important. And then the management and the subsequent dealing of the patients, and some young discussant or the presenters, they are telling about the heart failure clinic. That is very important. In every center, in every cardiovascular center, there should be a heart failure clinic. Until unless you make the heart failure clinic, you cannot follow up the patients very nicely or very diligently, because the very chronic disease, patient refuse to take the medicine. Doctors are also becoming impatient in dealing the heart failure patients. It is the experience of everyone. So whenever I first get a patient, I said that you should have the patients, I should have the patients if I treat you properly. So that is very important. And the heart failure clinic will deliver the services very diligently. With this saying, I think our presidents of the different national societies, they can contribute with this discussion matter. I can keynote speaker. I think he is the first person to be involved to have their comments on this young girl's presentation.
Yeah. Can I take the first slot, Mr. Chair?
Yeah.
Thank you. Well, I'm Dr. Kuiko from the Philippine Heart Association. Of course, Philippines is a part of a low-income country, but let me speak, of course, of the low-income to middle-income countries. And if you look at the data, of course, Southeast Asia, except, of course, Singapore and probably Brunei, most of us actually belong to a low-income to a middle-income countries, and we almost have the same, peculiarities and dilemmas as far as managing heart failure. And if you look at the data from the Asian Registry that was presented by Dr. Chen, Southeast Asians actually have the worst outcome as far as heart failure is concerned, and the Southeast Asians have actually or had the most comorbidities. So you are talking here of coronary artery disease, diabetes, chronic kidney disease. But in particular, I think among Southeast Asia, we have to highlight the presence of rheumatic heart disease. If you listen to the presentation from India and even from, was it Nepal? We took note of the high incidence of rheumatic heart disease contributing to heart failure, and that is very important. So we have to tackle the risk-specific factors for developing heart failure in each country and as a region as a whole. So before we can, in fact, do some, curb the incidence of heart failure. But there was a challenge from Thailand, I guess, that the APSC should come up with a protocol or a clinical practice guidelines in general. But the way I see it is, if you look at the profile as presented by Dr. Chen, the Northeast Asia, composed of Taiwan, Japan, South Korea, and Northeast Asia, they have different subset or profiles of patients, really more on preserved heart failure. But if you look at low-income countries, Philippines, India, even the South Asia, we are more of reduced heart failure, and we have different problems. So I think if we will try to make a sort of a guidelines, we will have two. For the Northeast and probably for the Southeast and South Asia. Now, emphasizing on that.
We are very short of time. I think only 7 minutes is left, and every president of the National Society is allotted 1.25 minutes.
Okay, yes, Mr. I yield to that, Mr. Chair.
1.25 minutes every president of the...
Okay, Dr. Abdullah, this my time, I think. It's a short comment from me. I'm Adi Media Ambari. I'm from Indonesian Heart Association. I think it's very interesting from the young speaker and then talk about the prevalency. I think it is very important. One point that I should give that management of heart failure is not just give a medication. Cardiac rehabilitation is very important. As in Southeast Asia, I think we really know that prevention is very important, primordial prevention. I'm really interested with the Philippines. You have a national heart failure network. It's been that heart failure is very big problems in not in Southeast Asia, not just in Philippines, in Indonesia too, I think. And then we should have a collaboration with the governments and then make a program like this network, because in the futures, as I think that's in Japan, because in the future we cannot just by ourselves. I mean that the cardiologists solve this problem. We need a non-physician network for that one. Yeah, we try to involve our community for that. And then the other things about rheumatic heart disease. Rheumatic heart disease is a big problem too in Indonesia. We have a discussion about that. Early diagnosis and prompt treatment. We try to collect the data and then try to looking for the patients, because as well as you know that mitral stenosis come earlier in our country, about 35 years old, and then but it's very different in Europe. Of course, that I think that vaccination is very important for the eradication of rheumatic heart disease, and then I think this is ongoing, trial for the rheumatic heart disease vaccination. I think that's all. Thank you very much.
Yeah.
Good afternoon, everybody. My name is Izam. I'm from the Brunei Cardiac Society. So I guess I would just add a little bit to what my fellow president representatives have said. So I can speak from a Bruneian perspective. So despite being a small country of about 500,000 people, we have a robust primary PCI network, but yet we see a lot of patients with HFrEF. As you see from my colleague's presentation, the majority of heart failures in Brunei are those with reduced ejection fraction. And the etiology remains ischemic heart disease. And the main reason for this is that despite these patients getting primary PCI, it's more a problem of them presenting late to the hospital. And this we have identified as being a lack of probably education towards the patients for primary prevention. So this is something that I can't stress enough, educating the population to recognize the symptoms, present early to hospital, get timely intervention. This could be the way forward to reduce the incidence of heart failure. The other problem I see a lot in Brunei, I don't know whether it's been mentioned by any of the presenters, is that there is a reluctance of our patients in Brunei to come and see the doctors. They prefer instead to try traditional herbal medications, sometimes mythical medications. They prefer to see witch doctors instead of presenting to the hospital. So this is also, again, a problem with education. But otherwise, I agree with whatever's been said. Heart failure remains a major problem, whether it's in Northeast Asia or Southeast Asia or South Asia. And it's something that we should look into preventing and reducing the incidence in the future. Thank you.
Hello, I am Dr. Dung Minh. I come from Vietnam Heart Association. I'm working at the same time in the University of Medicine and Pharmacy. Concerning about the heart failure, we have some comment as below. First, also, I would like to congratulate on the young speaker. Have many excellent presentation. For the prevalence of heart failure in Southeast Asia or Asia Pacific, I think it's the same, about 1 or 2%. In Vietnam also. Right now, our population rise until 100 million of population. So we have a big number of the heart failure in our population. It's a high burden also. So besides the diabetes and hypertension, right now we concentrate on heart failure, treatment and prevention. Concerning about the diagnosis, I agree with the young speaker that one of the big problems that is how we have many means, methods to have a good diagnosis in case of HFpEF. But normally we apply only biomarkers and some data of ultrasound, echocardiography only. But we're now lacking many sophisticated examination. For the treatment of the heart failure, I think it's very difficult to reduce the number of the HFpEF. With the HFrEF, recently we have many clinical data, especially the recommendation from the ESC and ACC. But for the HFpEF, we are lacking. Recently, we have some new drugs such as SGLT2 inhibitors and RNA, but As you know, the new drugs is a little expensive, so we can't apply for all the population, especially the limitation of social insurance for the low middle income, for example, in Vietnam. And then follow up the patient. I think there are two things very important. We must emphasize this afternoon with the discussion with our president in Asia Pacific.
Only 10,
the first one,
10 seconds left.
Yeah, that's either follow up the patient, how to follow patient, and the persistence of the patient, and the second one, that's either prevention. And I agree with the rheumatic heart disease is one of the most important in Southeast Asia and Asia Pacific also. Thank you.
Thank you very much for the
Mr. Chair, this is just an urgent motion. Of course, the presidents for different countries are here. May I actually suggest to have a session later in the future to talk about heart failure in Asia so that we come up with a consensus. This is a message
with more
to the
time,
leadership.
with more time. More time is needed.
Yeah, we have to set another meeting for this to the AFC.
Thank you very much, everyone.
Thank you for great discussion. I'm sorry for the very tight schedule. So please come to chairperson. The next session is intervention session. So please come all members in front of here, and I invite two chairpersons. One is Dr. Ako from Japan.
Okay, let's move on to
thank you.
coronary intervention sessions. My name is Junya Ako from Japan. I'm chairing this session with Dr. Srimaha Chota from Thailand. So all the young members and presidents, please come up to the stage. And I would like to welcome the keynote speaker from Pakistan, Jawad Akbasial.
You have 5 minutes for presentation, and for and for the young interventionist, you have only 2.
Thank you very much. It's a great opportunity to be here, and I'm thankful Professor Herata and JCS for inviting me and giving me opportunity to talk in front of great audience. So definitely when I was looking this topic that is peculiarity and issues to be solved by coronary intervention in the Asia Pacific Society region, I remember my friend Alan told me last night that once we are united, we are more powerful. So we can fight this disease very well. Otherwise, this Asia Pacific region, it's by conflict of interest is done, and it's very heterogeneous in terms of cardiovascular burden, such as South Asia has disproportionately high cardiovascular burden, cardiovascular mortality, cardiovascular related disability, adjusted life year lost, and QALYs. So it's not, you cannot universalize, as we have discussed in heart failure session, that it cannot be universalized because people from West learning their interventional technique from Japan, and fortunately Japan is also in Asia Pacific region, and countries like Nepal, like Pakistan, like India, which are struggling with intervention, are still in the same region. So this slide has already been shown in this conference. I have seen it already projected in different sessions. You can see here that how diverse we are as far as cardiovascular disease or disability adjusted life years are concerned, from West to South to Asia, and in particularly Southeast Asia. So if you look how Pakistan is behaving, or how Pakistan along with other Asia Pacific regions, there is condition is a bit more worse, that Delhi's, according to rheumatic heart disease, ischemic strokes, intracerebral hemorrhage, and a lot of other disease, we are far more higher than rest of Asia Pacific region. So what points I have accumulated to be discussed here, that what are peculiarities and issues to be solved. So what are coronary intervention in Asia Pacific region faces several peculiarities and challenges. Number one, there is diverse patient population. The region encompasses diverse ethnicities, cultures, socioeconomic background, leading to variation in disease prevalence, risk factors, and treatment outcomes. You all are agree with me. Another point, there is a high prevalence of cardiovascular risk factors in different areas. Like many countries in Asia Pacific region have high rates of hypertension, diabetes, obesity, smoking, which increases burden of coronary artery disease and its complication. Number three, there is limited access to health care. As one of our friends from India told us, there is very low penetration in rural areas. So rural areas and underserved population often face barriers to accessing specialized cardiac care, including diagnostic tools and interventional procedure. Then variability in healthcare infrastructure. You can't compare Japan's healthcare structure with Brunei or maybe Nepal or maybe with Pakistan. There is a significant variability in availability and quality of healthcare infrastructure across countries in the region, affecting the provision of coronary intervention. And cost, that's more important, because we in our country usually we don't have insurance support. In Pakistan, might be some other countries as well. There's economic disparities within the region may limit access to advanced treatment and technologies, leading to disparity in outcome-based patient and ability to pay. Then there is a unique anatomical consideration. In our population, their coronaries are very small. Some population in the region may have unique anatomical characteristics such as smaller vessel diameter and variation in coronary anatomy, which can impact procedural success as well as outcome. Then cultural and language barriers, because I am speaking here in English and a lot of Japanese people don't understand, but they are far more higher. We have to learn Japanese if we want to come here. Then effective communication, as you know, there is language barrier with the patient from diverse cultural and linguistic background is essential for informed consent, adherence to treatment, and post-procedure. So there is another now. There is some positive side of Pakistan as well as far as coronary intervention. And I can say that we have a cardiology network which continues in Sindh province. The lower part you can see, and we have 10 primary PCI capable hospitals, and we did 19,000 acute coronary syndrome angioplasties last year. So probably that's world record in our whole setup. And out of the 19,000, 15,000 were primary angioplasties. And this has been provided with the government, because in our province, government is providing funds and everything is free of cost. So what I have drawn conclusion from this discussion is that there must be a multifaceted approach, improving access to healthcare, enhancing infrastructure and training, implementing preventing measures for cardiovascular risk, promoting research to understand and address region-specific issue of coronary intervention. With this, I thank you all for patience listening.
Thank you, Professor Sao. So we have four presidents from for the discussion. First, Dr. Mankan Ausi. Oh, okay. Okay.
So we'll go through young speakers' presentation next. So please be reminded that there's no session afterwards this, but we have a cruise ship to catch. Okay? Okay, that's an important thing. So please be brief. All right, Dr. Ueki, please.
Thank you very much, Professor Ako. So we have to hurry. So otherwise we'll miss the dinner for cruise. So let me quickly summarize the basic information in Japan. So from my perspective, actually we don't have the official data for this. But in Japan, most ACS patients were treated by emergent PCI. For CCS, so PCI is considered as a first option, and only patients with extensive CAD undergo CABG. But the treatment choice largely depends on the local expertise. And the percentage ratio of ACS to CCS may be 40% to 60%. And so about the selection of antiplatelet therapy, so we follow the international guidelines. So for CCS patients, so the short-term DAPT followed by single antiplatelet therapy is a standard therapy. And for ACS patient, so we prescribe 1 year DAPT with low dose prasugrel. And so major diagnostic tests for myocardial ischemia assessment include FFR at 40% and RI and stress ECG. So what are the current problems in Japan? So from my perspective, so first, the management of elderly patients. So actually, so Japanese population is quite aged population. I think the one of the most aged population around the world. So national data shows 30% of 125 million population is aged more than 65 years old in Japan. And so the adoption rate of physiological assessment remains quite low for CCS revascularization. And the cost of revascularization. So due to the new available devices such as intravascular lithotripsy and drug-coated balloon, so the medical cost is so rapidly increasing. And finally, so maintenance of the emergency care system. So due to work system reform by Japanese government, such as a current topic in Japan. So this results in that some areas in Japan are facing will face a difficulty to maintain the emergency care system. So that's it. Thank you very much.
Thank you. Next speaker is Dr. Ki-hon Choi.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. My name is Ki-hon Choi from Samsung Medical Center, South Korea. Today, I'll be shortly talking about the coronary intervention from Republic of Korea. I have no financial disclosure in this presentation. Here are the baseline information of coronary intervention in my country. The KPCR registry, the nationwide Korean PCR registry, was published in Korean Circulation Journal as 2016. Among this cohort, about 70% of patients were presented with acute coronary syndrome, including 17% of STEMI, and remaining 30% of patients were presented with chronic coronary syndrome. The annual PCI volume in my country is about 70,000 cases per year, and in-hospital cardiac mortality rate was 1.8%. Among this cohort, 3.1% of patients was developed cardiogenic shock due to acute myocardial infarction, and annual number of cardiogenic shock is slightly increased over the decades, but annual in-hospital mortality of cardiogenic shock is slightly decreased. This slide shows the current problem of coronary intervention in our country. As you can see these figures, there are substantial significant variations in terms of the mortality in cardiogenic shock with AMI according to tertiary centers, ranges from 10% to above the 50%. In particular, patients living in the other regions was associated with significantly higher risk of in-hospital mortality than those in the Seoul or metropolitan city. I think this parity in mortality rates between region and centers for patients with AMI complicated by cardiogenic shock are the current problem from Korea. And another problem is that fewer physicians are willing to perform interventional procedures due to a desire to avoid emergency. In particular, South Korea is currently facing the conflict between government and doctors for the issue from the medical student number. So I hope that this conflict will be resolved soon. And I'm also curious about the trend of the number of interventional cardiologists in other countries. Thank you for your attention.
Very nice presentation. So the next speaker is Stanley Malang from Papua New Guinea, please.
Good afternoon, everyone. Looks like I'm the only one from the Pacific, so maybe I'll have enough time to talk. It's just a joke. All right. I have no disclosure. This is Papua New Guinea. As you can see here, we are border with Indonesia. We have 3 major ethnic groups. If you don't know Papua New Guinea, this is Papua New Guinea. And I'll talk briefly about that. First of all, I'd like to apologize. In our Pacific region and in my country, intervention is a new field, and we don't have data, and we don't have most of the information. We'll need more help from the APC members. Currently, we started intervention in my country in 2021. Current treatment for ACS, we have PCI. In other provinces, they use thrombolytics. They still use the whole streptokinase. Alteplase and tenecteplase are very expensive. We don't have cabbage in our country. We don't have an operating theater for coronary bypass surgery. Treatment option for chronic coronary syndrome, mostly PCI at the moment. Other centers, they medical treatment, and they refer them to Port Moresby General Hospital. Percentage, these are just estimated percentage of ACS and CCS in my country. It's estimated about 0.3% of the population. We have 10 million population. And the number of coronary cases are increasing exponentially since the establishment of cath lab service in just recently, 2021. Patients in our cath lab, 10% of ACS and around 20% of chronic coronary syndrome. The choice of antiplatelets currently only aspirin and clopidogrel. Few patients are on ticagrelor, but we don't have the other antiplatelets. Diagnostic tests that we have at the moment, stress ECG, stress echo, CCTA, and IVUS and FFR. This is the procedures at the moment we are currently performing in our cath lab. We recently, last year, bought RotaPro and a HIVUS machine, and we just did few cases. And these are the cases that we did. And last year, this total number of cases that we did in our country. It's a low to middle income setting. Current problems we are facing at the moment, patients take a while to present to our cath lab. We don't have enough consumables, no vital equipments, no ACT machine. Big challenge we have only 5 doctors in a population of 10 million. 3 of them are expatriates. And only 2 local, one is a clinical cardiologist is about to retire next year. And only 1 intervention cardiology trained in Singapore, Dr. Boko. And now we are fortunate to have a Vietnamese who is helping us to build intervention service in Papua New Guinea. Most of the cases have been misdiagnosed because of lack of knowledge and training and lack of diagnostic equipments. Like you don't have ECGs and echoes in most of the provinces. Only in the national capital, the capital of the country, you have all the services available. And it's very expensive to purchase good medication. We don't have medical insurance cover, and non-compliant to medication is a very big problem. And in the Pacific, I didn't mention about the entire Pacific because only Fiji has got 1 cath lab, but like it's not continuously operating. And only in Papua New Guinea, we have 2 cath lab in the capital, but not enough intervention cardiologists. But we are fortunate to have 3 expatriates, and currently 2 locals are training. So we need more help. Thank you.
Right. Thank you very much. Let's move on to the next speaker, Samrani from Cambodia, please.
So, good afternoon. I'm Dr. Samrani from Cambodia Kalamat Hospital. I have conflict of interest. So, as you know, so far, the Cambodia has the bad history. We have a Khmer regime with almost 3 million was killed, health system was destroyed, and the doctor was killed. After the war, we have only 8 doctors remain for the country. And for the cardiologists, we have start in 2002 with one doctor for the whole country and one interventional cardiology for the whole country, is Professor Sokju. So for the STEMI acute coronary syndrome was created in my hospital, the first center in the country. So we had the data from 2004 to 2018, we had almost 4,000 cases. For the first 5 years of the interventional, we had less than 100 cases per year. But now we have almost 1,000 cases per year for acute coronary syndrome. And among them, the STEMI represent 67%, and non-STEMI is 33. For the PCI, all the data in our center, the PCI rate was 55%. It's a bit low compared to other because on the first 10 years, we have low PCI rate. We have almost 30 to 40% of primary PCI. But now we have almost 80 to 85% primary PCI. Among them, the PCI was almost 90%, and the CABG only 5%, and fibrinolysis we have used less, only 0.3%. For the antiplatelet therapy in our country, we still use aspirin and clopidogrel for the first choice, and the ticagrelor we have used less because of the finance problem. So here is the current problem in my country. Firstly, I would like to introduce you about the health finance and national health insurance in Cambodia. So our population is almost 17 million, and we have the low income country. And for the health finance source in our country, most of the case is out of the package of the patient. The government represent only 22%. And for the national health insurance, we just start in 2008 with National Social Security Fund that government will apply, and almost 1 million people was covered, and till now there almost 6 million people was covered. So as in the same in Asian country, we have the rapid growth economic, but make the rural area and the urban area high different. So you can see it's the rural area in Cambodia and the capital Phnom Penh city in our country. So in our health system had the main problem like also the imbalance of the rural and the urban city. So here is the health center in our country, and this is the provincial health system in our country. And we have 3 national centers that can provide the PCI in our country. And you can see the first picture on the right side is my hospital, the new building. And you can see the small building inside that is our center, the first center in our country, the first center. So now it becomes small like this. So here is our problem right now. For the patient, like other country, we have traditional culture. The patient don't want to go to hospital. They try to traditional medication, auto medication before go to the hospital. And for the EMS in our country, we don't have the.
You have to conclude.
Yes.
Because of the time.
We don't have probably trend. Only the provincial has the probably material in the ambulance. And for the ER, we don't have the national STEMI network. We have only provincial system that we create since 2015. And fibrinolytic is still not practical. And for the cath lab, we have only in the capital city, Phnom Penh, for the whole country. Thank you.
So the next speaker from Singapore, Dr. Jonathan Yap, please.
Good evening. It really gives me great pleasure to be able to talk here today. Hearing from my colleagues in Cambodia and Papua New Guinea, I just have to say that, really very respectful of the challenges that you guys face. And, we are really so blessed here in Singapore, and we still complain, sometimes. Okay, so anyway, in Singapore, we have two main registries. We have an AMI registry that the government runs, and some of this data is from there. So this is some data from 2021. Singapore saw a total of about 2,700 STEMIs and about 9,000 non-STEMIs. And you can see the mortality rate for the STEMIs was about 10%, and for the non-STEMIs about 4%. I want to highlight the little table here below. You can see the distribution of the burden of cardiovascular risk factors among our MI patients. A lot of them have high blood pressure, high cholesterol, are overweight, and have diabetes or smoke. So really a very high burden of cardiovascular risk factors. It's a little bit of our door to balloon time. If you look at the column in gray, that's the amount of the percentage of patients who achieve a door to balloon time of less than 90 minutes. And if you look at this gray line here, you can see the average, the median door to balloon time. So you can see from 2011 to 2021, we have improved from about 70 minutes to below close to 40 to 50 minutes of door to balloon time. We also have one more registry in Singapore. This is for among the public hospitals. It's a PCI registry where all the different public hospitals contribute their PCI data. And if you look at the first half of 2022, you can see that in Singapore, public hospitals, we do an average of about 800 PCI cases. So a year, much less than other countries, but about 10,000 PCI cases across the board. These are some of the results. If you look at the elective caseload, which is more interesting, and without the mortality rate is about 0.3%. So for STEMI and non-STEMI, those with cardiogenic shock do badly, as we all know, and as we have seen from the Korean data. STEMI about 50% mortality, and non-STEMI about 35%. Just a quick one, we are about half-half for ticagrelor and clopidogrel for our second dual antiplatelet therapy. So this is my last slide. Just want to say this is one of our problems. If you look at the incidence of AMI, both STEMI and non-STEMI from 2011 to 2021, it's been increasing steadily. And this is really largely attributed to probably one of the affluent lifestyle in Singapore. The burden of cardiovascular disease, diabetes, high blood pressure is all increasing. Even with the improvements in technology and medications, our case fatality rate for MI has not really truly improved too much over the last decade. And what we are seeing is actually a lot more severe disease. These patients are coming in with triple vessel, left mains, and really complex disease. And I think that's one of the problems that we have to tackle with in the future. Thank you.
The next speaker from Pakistan, Dr. Syed Ali Ahmad Sadi.
Thank you very much. So I came here all the way. We are here in Japan, and I came from Pakistan. So this is a map of Pakistan. We have two sort of systems. One is the private sector, other one is the public sector. In the private sector, patient usually pays by himself, but in the public sector, we have two areas. In these three provinces, we have a health card system in which the patient gets facilities from his health card. And the other one is the one which Dr. Javed Syal already mentioned, is the system that is running in the province of Sindh, which has done almost more than 19,000 primary ACS PCIs in the last year. And here the system is just like that. Everyone get the chance within the 2 hours to reach to the primary PCI center. So considering the treatment options, we have for ACS, we have the treatment for STEMI and non-STEMI in mainly the big cities. Regarding the PCI for chronic coronary syndrome, we have available for complex PCI, we have limited options like CTO, IVERS, and ROTA. They are available, but only in the major centers. OCT is not yet available in our country. Considering the percentage, we cannot exactly tell like others because we don't have any national registry, but the probability of ACS is more. That is, the interventions in ACS are more, they are around 60%. Regarding antiplatelet therapy, clopidogrel is still the first choice in majority of cases. Ticagrelor is present, but it is difficult to get because of the higher cost, and it is not available everywhere. And regarding the diagnostic test, we have a majority of them, but only in the major cities. We have different problems in our country. Number one is the higher cost. Other one is that we don't have a database available throughout the country. Another issue is that after primary PCI, the patient have problems in getting drugs. And the compliance is, again, a big issue like other countries. We have a limited availability of advanced modalities like IVUS, like ROTA, and other advanced modalities. In remote areas, the access to the cardiac care is often difficult. And another thing is that because our priority is ACS, so the patient with CCS, they often get less chances for intervention than primary PCI. Thank you very much.
The next speaker from Malaysia, Dr. Chong Cheng Lim.
Hello, good evening, everyone. I'm Chong from Malaysia. Pleasure to be here. Given the task to present coronary intervention in Malaysia, just to show you our National Heart Association logo. And with that, actually, we have 7 sub-society with the logos at the bottom. There are no conflict of interest, so these are the basic informations. Actually, we have our national data, we call NCVD, PCI data, which actually is initiated by our National Health Association of Malaysia rather than the ministry, but we are in collaborating with ministry. There are 12 private hospitals included in this registry and 10 public hospitals and 3 university hospitals. Not all hospitals are included in this registry, including maybe about 30 to 50 of private hospitals. So for the past 2019-2020, we have 24,000 of PCI. Those patients that underwent the PCI in Malaysia are relatively young, the mean age of 57s, as opposed to other registry, maybe about 60s, 70s. And reason behind, probably because we are a younger age countries where our median age is same with the median age of the world, about 30 years old. And comparing to Japan is 49 years. And perhaps our cultural belief in those elderly patients, they are more keen for conservative management instead of a PCI, and perhaps younger onset of the heart disease. And those patients undergo PCI, 82% of them actually overweight or obese, all right? And 60%, more than 60% are hypertensive, more than 50% are dyslipidemia, and about 50% are the former ex-smoker, and 44% are diabetes. And of all the PCI patients, only 13.7% of them have the ischemic testing. Why is that so? It's because majority of the PCI has been done for patients with ACS, about 78.5%. And only 20% of them are actually stable CAD. And in hospital, 30 days mortality is 6 months or 1 year. Yes, as such, from the in-hospital is about 1.4%, and 1 year mortality is about 6.46%. And our routine PCI route is through radius. Okay, I'm sure the rest of the world are the same. And what are the current problems in Malaysia? As you can see, I can put the scale here about 200 kilometers. Okay, this is east of Malaysia Peninsula for those who are not familiar with Malaysia. This is the West Malaysia, this is the East Malaysia. And you can see that the scale is 200 kilometers. In the whole of the Sarawak states until here, okay, so there's only one government center, PCI center, okay, across this length of about 800 kilometers. Okay, and in total, we actually have about 13 or 14 government hospitals, and the rest are the privates. Okay, but the problem is there's maldistribution of cardiologists, as you can see from our national data. About 311 of the cardiologists in Malaysia are in private now, including myself. Okay, only 21% of cardiologists are in government, like Dr. Alan Fong. But of those, 80% or 79% of the PCI actually is done in a government center. Only 20% is done in private, all right? So it's total maldistributions. And among patients presented to PCI center, only 60% of the STEMI patients were able to achieve door to balloon time of less than 90 minutes, as opposed in Singapore, they managed to achieve more than 90%. Okay, perhaps of the geography and you can see from our map here. And among patients presented to non-PCI center, transferred to PCI center, there's only 36% of them achieved door-to-balloon time of less than 120 minutes. Of 4,960 patients over these 2 years with STEMI, only 1/3 of them underwent primary PCI. Actually, 2/3 of them underwent thrombolysis, being whether it's structural kinase or metallase. And of which also not many of them have invasive procedure done. You can see here the rescue PCI, 14%, about 15% of them, pharmacoinvasive 18%, and some of them have this delayed or routine selective PCI, which has been done more than 24 hours post thrombolysis, 34%. And a large percentage of them are actually have no PCI done. So I think that is our current main problem in Malaysia, the maldistributions of the cardiologists. And in Singapore, just our neighbor countries of 5 million populations, they have about 200 over cardiologists. In Malaysia, we have less than 400 for 34 million populations. With that, thank you very much.
The last speaker and only one lady interventionist, from Sri Lanka, Dr. Disna Amaratunta.
Good evening to all of you. Thank you very much. I'm Dr. Disna Amaratunga, consultant cardiologist from Sri Lanka. Thank you very much, APSC as well as the JCS for the opportunity given. So the outlook of the lecture is a little bit different from the intervention. It is actually more towards different kind of innovation together with the tranquility, wildlife, natural beauty, and yes, it's my country, Sri Lanka. Yes, so Sri Lanka is a country with a free health policy, and and in addition to that, it operates even without an insurance coverage. So we don't have the insurance backup, even though that we have the free health policy. So irrespective of the level of financial status, ethnicity, as well as the age, so the citizens, all the citizens are entitled to get the free health coverage. So obviously the government sector is the main healthcare provider of the country, but we do have a private sector, very well developed private sector. But main problem is the private sector is mainly located towards the central city, right? And so I don't have anything to disclose. So now when it comes to the management of the acute coronary syndrome, the STEMI management, we do have the primary as well as rescue PCI facilities available in our country. And we have 13 cardiac catheterization labs in government sector and 12 in private sector, that is for 22 million population. And we do have nearly 150 consultant cardiologists. Most of them are interventional cardiologists. So even though that we have a good number of cath labs as well as cardiologists for this amount of population, our main problem is the discrepancy in the distribution of cardiac catheterization laboratories. So nearly 2/3 of these laboratories are situated mainly in the central province, in the vicinity of the capital city. That is mainly because all the private sector cath labs are located mainly in the capital city. So the mainstay of STEMI management in my country is with thrombolytic therapy followed by rescue PCI for most needy patients. So the percentage of primary PCI, the country figure is somewhere around 10%, but the STEMI patient 10%, but in Western province, it is more than 30% due to the reasons that I have already explained. So when it comes to the thrombolytic therapy, we do have tenecteplase and we rely more on tenecteplase even though it is bared by the government, and the use of tenecteplase to streptokinase is 9 to 10 percentage wise. So when it comes to the NSTEMI as well as unstable angina management, the mainstay of management is with the low molecular weight heparin. It is mainly the enoxaparin, and then we also consider the high-risk patients for early coronary angiogram plus or minus PCI. And then when it comes to antiplatelet agents, main dual antiplatelet combination is aspirin with together with clopidogrel. And we do have ticagrelol, prasugrel. Those are available in the private sector. The affordable patient, even though that they are in the government sector, they have the freedom to take it from the private sector as well if it is needed for them. And we don't use IV antiplatelet therapy in routine basis, but we do use them during rescue PCI or the primary PCI where necessary, especially the 2B3A inhibitors. And when it comes to the treatment options for chronic coronary syndrome, so we do consider the coronary angiogram for the symptomatic patients or patients with inducible ischemia. And the elective PCI, we do simple to complex form of PCI, including CTO interventions. So we do have the, when it comes to the CABG, we have conventional as well as the mid-cap procedures. So the diagnostic test for myocardial ischemic assessment, actually, at the moment, we are mainly rely on the exercise ECG and the stress echo because of the limitations in our resources. Those are the the tests are widely available in the government sector, and we do have cardiac MRI as well. But when it comes to the private sector, we have most of the tests to diagnose the myocardial ischemia. So our current major problem is the funding, because as I explained, the main source is the health budget allocation and all the coronary interventions, everything done free of charge. So it is a major challenge to us. And because of now, at the moment, the country is undergoing very, in the height of the economic crisis. So the cath lab consumables, the price of the cath lab consumables has gone up exponentially. So it's really a problem for a country like us. And we do have the other problem is, even though that we have the a good number of cath labs in our country, due to the discrepancy in the distribution, the access is limited. And because of the same reason, the rescue PCIs are done over primary PCIs. So it is once again an additional expenditure to the government, because they have to spend on the thrombolytics, then later spend on the intervention as well. For both, the government is spending. And we have the limited, and the other problem is the limited availability of the intracoronary imaging. Even though that we do a lot of coronary interventions, complex coronary interventions, this is a real limitation for us. So, and in addition to that, there's a limitation in the availability of drug-eluting balloons, rotablator, IVL, ECMO, as well as impeller, because once again, due to the poor resource setting. So, in addition to all these things, we do have long waiting lists for routine coronary angiograms, PCIs, as well as the coronary bypass surgeries. And on top of everything, our current major problem is the brain drain. So that is because of the ongoing economic inflation. Even though it's a country of like having the literacy rate of 99%, and the doctors who are the products of free health as well as free education are now leaving the country. And so many problems behind that. Most of the doctors are at the tax rate of 36%. So this is the current major problem in our country on top of everything. But when it comes to the knowledge of our consultants, and we do have extensive cardiology training of 5 years, 3 years in Sri Lanka and mandatory 2 years in a developed country. So even though that we are coming from a resource poor setting, we make sure the quality of the consultants that we are having, and we feel that it is like, our country is like a racing car in a traffic jam. So whenever we get the resources, we know that we can boost up. With this hope, I conclude my talk. Thank you very much.
Thank you. So we have for this consent from the President of Mongolia, and Papua New Guinea, Malaysia, and Singapore. You have 1 minute. 1 minute.
1 minute. Remember, we have a cruise ship to catch. Okay, 1 minute, please.
I will be very fast. So I'm just thinking that we are very different countries with very different scenarios, and we are doing very different, good practices to overcome all those obstacles in each country. So I was thinking that if we can come up with such kind of documents that we can promote each other's good practices and we can learn from each other. It will be very nice. Thank you.
Okay, one word from Dr. Noah Papua.
Hi, I'm David from Singapore.
Oh, David from Singapore.
Hi, well, I think in 30 seconds, I want to congratulate all our young cardiologists sitting behind us. And I think I want to congratulate because they actually know the issues that their own countries face. And I think this session just actually illustrates that. And I think hopefully in the future, like heart failure, we have more time to sit down and have smaller focus group discussions to talk about each other's challenges and from different perspectives, how we potentially can overcome them.
Okay, Aram. Oh, okay. No.
Thank you. And Noah is my name. I'm actually a cardiothoracic surgeon. And I think I'm fulfilling the keynote speaker's recommendation as a multidisciplinary approach. So that's why I'm here. I'm very thankful for the JCS for having me and my colleague here. I think what was presented, we are challenged with setting up a service and also already a big underlying problem that we have. Rheumatic heart disease is our main problem with congenital heart disease, and now lifestyle disease with coronary artery disease coming up. The first recorded coronary heart disease in our country was in 1996, but now it's gone very exponential. And we are very delighted that such meeting we come and learn from you, from your programs that is already running. We are just establishing it. How do we get there and how do we progress from there? So thank you very much.
Aram.
Thank you very much. I think I'd like to thank the APSC and JCS for bringing this session together to show how many things we have in common, compared to what we are different. I think the common things are about access and about funding. And I think it's the same for every country, whether it's a developed country or a low to middle income country. I think for coronary intervention, the biggest benefit is in the ACS population, whether it be STEMI or non-STEMI. And for this, early invasive strategy is something that we've worked on for one generation. You can see the door-to-balloon times. We have directly impacted and improved where we have started the service. So there's one metric I hope the APSC countries can look at, which is the total ischemic time, symptom time to hospital time. And this is something that I think is common. And the only way we can improve STEMI outcomes or ACS outcomes is to have an all-stakeholder approach. We need to generate the data so that our policymakers can look at this as well, and not only wait for them to come to a hospital where we are already working our best because of the cost and the access issues. Thank you very much.
Thank you very much. You have
to save the time, I'd like to make a closing remark.
Okay. Yeah.
I'm very impressed at the presentation of young speakers from more than 15 countries in this region. I really didn't know how hard the situation is in Cambodia and Papua New Guinea. Thus, I really consider such kind of difference on the basis of sharing point in many countries in this region. I fully agree with the comment from the young speakers in Thailand. Our guidelines are just copy of global guidelines based on Caucasians data. I fully agree with that comment. Actually, Korean guidelines, 95% copy of the global guideline because of the shortage of our own data. But in terms of PCI, with continuing research, we get some discrete difference between Caucasian and Asians in terms, for example, risk ratio of bleeding and thrombosis. Thus, we were able to make more detailed, customized regimen regarding antithrombotic therapy after PCI or TAVI in Asian, at least in Northeast Asian. Thus, when we apply such kind of strategy to heart failure, of course, human beings are not so different depending on color of skin. I believe biology of heart failure can be applicable to Asians that is based on Caucasians. But there may be some subtle difference in biology between Caucasian Asians in terms of catecholamine system, renin-angiotensin-aldosterone system, sodium glucose co-transport activity, or mineralocorticoid-induced fibrosis. Thus, with the future, we make some progress in research, then we can make some customized Asian guidelines. That is my hope. But the problem is heterogeneity. Two levels of heterogeneity. The first one is ethnicity. Even though we call each other as Asian, Northeast, Southeast, Middle East. Because some guys mentioned before, we can have some different guidelines even in our AP regions. The second problem in heterogeneity is difference in health economic issue. So kind of economic status determines healthcare service, determines the quality of practice and education. Thus, we may not be able to get some unified guidelines in our society. How to get through such kind of difficulty? I don't know the answer, but the simple thing is just frequently meeting each other, communicate intimately, understand each other, and we can share the know-how with each other. We can share the establishment process of KPCI, KTAVI registry, because I have done that. We can share the know-how to establish Korean AMI registry. That is not, all of those, not government-driven. We didn't believe government. So we try to establish our own society registry, because government registry is always used for a certain purpose. Thus, we always concerned about such kind of government-driven registry. That's the reason why we established KPCI, KTAVI, and KMI registry. And anyway, my final comment is, let's get together. First of all, let's meet each other annually, every year, at the annual scientific session sponsored by APSC, Dubai, at the first week of May. Next year, Busan, Korea, at the third week of April. Please remember. Then Taiwan, and then Japan. Thank you very much for your attention.
Thank you very much. Before we conclude, there's a group photo. So just 1 minute for group photo. So please come up to the stage for young cardiologists and those panelists. Everybody come up to the stage. Let's take a group photo.